Keep sending in both electronic and think of your oral questions as well.
Thank you very much, Ian. Thank you to the ASGBI, EA, HPBA for inviting me to speak on this topic. I think Nick raised a very good strapline there about what would I want for my mum. And I think it's true to say that many patients who come in through the front door with gallstone disease today are not treated in the way that we would like ourselves or our family and friends to be treated. They are given some painkillers, sent home. They're still suffering with their pain for several weeks afterwards before they're referred to an outpatient clinic before they eventually get on the list for what we knew they were going to have anyway, which is a cholecystectomy. So the aim of the new guidelines that we're developing was to see if we could stratify this and standardise it and come up with a pathway that would improve both the patient experience, become more resource and cost effective, and hopefully introduce some safer and faster elements to it. So why gallstone disease? Well, gallstones account for 30 to 40% of admissions on the emergency general surgery service. Are there any guidelines at the moment? Actually, surprisingly few. Guidelines for dealing with patients with acute pancreatitis have been around for some time, and the suggestion is that patients should have their cholecystectomy within 2 weeks of the index admission, although in newer guidelines from the American Pancreatology Association suggest that it should be on the index admission. Acute cholecystitis was a recent NICE review of which the summary really was that the patients should have their cholecystectomy within a week, although again international guidelines suggest it should be on the index admission. We heard from an Australian speaker earlier this morning that they try and get all their patients operated on within 24 hours of admission. But the majority of surgeons in the UK who provide acute general surgical services, acute gallstone surgery services, are not specialist HPB surgeons, and perhaps we need to provide some guidance for this. This is data that shows who's doing your lap chole. So in the UK, 600 colorectal surgeons doing lap choles, endocrine, etc., etc. Other one is really surgeons who don't fit into any of those major categories. So these will be probably emergency surgeons, stroke day case surgeons. Another two are surgeons who meet more than one category. So if we look at the number of procedures by subspecialty, you can see that actually HPB and OG, so upper GI surgeons, are performing only about a fifth of the laparoscopic cholecystectomies in the UK. And the majority, in fact, are done by day case stroke emergency surgeons. The median annual number per surgeon, however, is quite different. And if you want to have the surgeon who's doing most lap choles for you, you'd want to pick an upper GI surgeon. In fact, over 75% of colorectal surgeons are doing less than 20 lap choles a year, whereas over 75% of HPB and the same for OG surgeons are doing more than 20 a year. So, is there any variance across the world? Yes, there is. There's evidence from Australia, France, America, where they're driving the admissions, the surgery much faster than we are in the UK. Some of this is because it's a healthcare-based system and there's obviously an incentive for it, but a lot of it is really what we should be doing for our patients anyway. If you're admitted in Australia or France, your average time, your average length of stay following your admission, if you have a lap chole, is 36 hours. In the UK, it's 7 days because of the lag time to getting your cholecystectomy, as much as for the difference of management afterwards. And there's a wide variation in the UK practice. Here again, it just shows you that the median time in the UK is around about 6 days. And look at the scatter plot, which shows you in the UK, the proportion of patients at individual hospitals who are having their laparoscopic cholecystectomy within 14 days of admission with acute cholecystitis, varying from around 40% to very few of your patients getting operated. So what are the problems with provision of acute gallstone surgery? It's access at the most basic level. In some centres, you can't get an ultrasound for 2 or 3 days. In many centres, it's still regarded as not really an emergency operation. And for those of you who've been watching some of the videos on acute cholecystitis, we know that these patients, their gallbladders are horrible, often necrotic, and it's just as much as an emergency as many appendixes. There can be restriction of access to theatre lists. Most units now have an emergency theatre, but it's shared with lots of other specialties, and you can't get a gallbladder in because it's only a gallbladder, isn't it? It's not real emergency. And if we had provision of urgent lists that we could send a patient with standard biliary colic and home and get back within a few days, this will make life easier. There's the fear of the difficulty of acute laparoscopic cholecystectomy, which shouldn't be underestimated, and there will need to be some sort of provision of subspecialisation or handing on of those difficult patients to surgeons who are doing it frequently. And there can be uncertainty in how do we deal with the abnormal LFTs. Can I have permission to not necessarily investigate this further? And that may, and the skill mix again, may put people off doing it. So, if we take our patients with acute gallstone disease, we can easily stratify them into those with jaundice and cholangitis, acute cholecystitis, pancreatitis, or those with biliary pain. I slipped into calling it biliary colic again, but we must try and get away from that term. So on the basis of the 4 standard things that we do for any patient, with the exception of perhaps an ultrasound here, we can stratify them into those 4 groups. Essential things in the history, of course. Is it the first or recurrent episode of pain? Is it a typical history? Is it right upper quadrant epigastric pain radiating round in a band, lasting for more than a few minutes, probably a few hours, usually at night or often at night, maybe related to food? Are there other diseases that might alter what we want to do with this patient? Are they fit for intervention? There's a difference between the 25-year-old lady who comes in with biliary pain and the lady who's in a nursing home or the pregnant lady. Examination may reveal tenderness in the mass. Are there alternative diagnoses? Not everything with right upper quadrant pain is gallstone disease. A few patients will have malignancy or other diagnoses, obviously. And are there other problems that may occur, alter our operation? The ultrasound needs to confirm the presence of gallstones and state clearly whether there's dilation of the bile ducts or not. There may be other findings, obviously, pertinent to the patient, but neither the number or the size of the stones nor the correlation between the presence of fluid or thickness of the gallbladder wall have any bearing on the severity of the disease. Blood tests will need to identify acute pancreatitis and the liver function test, which will help us to stratify. So when we enter our pathway here, that's what we've done. We've taken ultrasound to confirm they've got gallstone, they've got a typical history of biliary pain, and we've done some standard blood tests. And then we can stratify them on the basis of that into the 4 boxes. So patients with acute pancreatitis will obviously be those with the elevated lipase or amylase and confirmation of gallstones to confirm it's gallstone pancreatitis. They should be stratified on entry into hospital, and within the 48 hours it should be clear as to whether they are likely predicted mild or in fact are severe. The mild will settle by definition and ideally should have a laparoscopy on the index of admission, but I'll show you later this doesn't happen, but they should have their cholecystectomy done as soon as available possible on the next urgent list. 20% of these patients will come back with further episodes of pancreatitis. The severe patients, we need to manage their organ failure. A very few of them, will require ERCP if their bilirubin is rising or they have cholangitis at the same time. The majority hopefully will recover, and at some stage, and this is more contentious, we'll need the laparoscopy, and the timing of that is more contentious. A few of them won't be fit for this, and there is evidence that doing a sphincterotomy will protect them against a lower risk of readmission with the same disease. I said that we're not doing very well. Well, this is the number of patients who are having their cholecystectomy within 14 days of acute pancreatitis in the UK. A few centres are managing to do quite well, and of course it won't be 100% because some of these patients will never have their cholecystectomy, but we're not doing very well. And this is even when you're in a hospital where you think you might be able to influence it, you can't always. So the next group of patients will be those that are jaundiced, and they may be cholangitic with high temperatures and rigors, or they may just be jaundiced with normal white cell count and systemically unwell. If they've got cholangitis, they need urgent treatment. These patients have a high mortality. They need fluids, antibiotics, and if appropriate, a high dependency unit. And they need urgent biliary decompression with an ERCP. The patients who are not systemically septic, we need to always think, is there any malignancy there? And they may need further investigations with a CT or MRI before an ERCP, or they may just need an ERCP and removal of their stone. And then on subsequently to have their gallbladder removed to prevent further episodes. Patients with acute cholecystitis, which we can really define, we don't need to be too pedantic about it. They may have the systemic features and the hot gallbladder and tender mass, but in reality, it will include patients who've got ongoing biliary pain that you can't get home because they've got severe biliary pain and they're treated in the same way. They need an emergency lap chole, and they should ideally be done on the same admission where possible. A few patients will be either too unfit, and this may actually be the patients who are on the intensive care, and may get by with a percutaneous cholecystostomy. How are we doing with this subgroup? Well, better. This is the number of patients who have undergo laparoscopic cholecystectomy for acute cholecystitis within 14 days of admission, and some centres are really managing to achieve this well, better than others. Is there evidence that we can, by introducing pathways, actually improve these outcomes? Yes, I'm pleased to say there is, and that's one of the reasons we should be pushing this pathway system forward. Here's our own hospital, 2009 data for the same statistic you were looking at, lap choles within 14 days of acute cholecystitis, 13.3%. After introduction of a specialist subsurgical HPB take, we pushed this up to about a third of our patients getting cholecystectomy within the same admission. Are there other evidence of variation? Are there other things that, by introducing pathways, we might improve upon? Yes, just to flick through a few of them. The average length of stay in some hospitals is very high. Why is that? Well, it's possibly because they're doing a lot more open cholecystectomies. There may be the significant differences in conversion rate for these emergency cholecystectomy rates. So all these things could be measured and could be monitored by ourselves and by the units to show that we're actually, the pathways are improving performance. So the last group are those patients who don't fit into the other groups. These are patients with symptomatic gallstone disease with biliary pain. And by the two simple tests of ultrasound scan to show dilated or non-dilated ducts and abnormal liver function tests, having excluded those with the cholangitis and jaundice, we can stratify them into 4 subgroups, which equate really to those with a minimal risk of bile duct stones, low risk, or the highest risk. And it really comes down to our approach of what we do about the bile duct. How interested are we to know that there's stones in the bile duct, and how are we going to confidently manage it? Do we want to know about it before the operation, during the operation, or after? And there may be an element of personal bias in here. We can investigate before the operation with MRCPs, endoscopic ultrasound, or in some centres, variations on the CT protocol. But the trouble is 90% of these are going to be normal, and that's a huge resource implication in your MRI scanner and delays the time to laparoscopic cholecystectomy in a number of studies by 2.5 days in the UK. So what we do in practice in most centres is that we selectively screen them for high risk, and that's what we're doing by putting in the abnormal liver function tests and the dilatation of their bile ducts. We're essentially stratifying based on the element of high risk. Interestingly, however, even when we clear the bile duct, when we come to operate on them, 17% of them who have cholangiograms to prove whether they've got stones there will have stones there. So it's not necessarily the best thing to preoperatively identify. Intraoperatively, we can do cholangiogram, or in centres where it's available, laparoscopic ultrasound, very cheap and very efficient, but it's highly skilled and relatively expensive bit of kit to have for an occasional use. But if you do this, you have to have this plan of what you're going to do when you find stones. And perhaps the most contentious area would say, well, I'm not going to investigate at all, really. I just find out afterwards who's got it, and we deal with the symptomatic stones only, which is actually, for that group, only around 5%. But I think that's probably a little bit too contentious for most of us. So what is the frequency of bile duct stones in patients with symptomatic gallstones in the general population? And these are 6 studies that show actually it's quite high. Quite a lot of patients walking around with their gallstone disease who have bile duct stones as well. Within those subgroups, we can narrow it down a little more. So if you've just got dilated ducts, and I'm careful here not to specify, this study, when we looked at 100 patients who were referred, it was just they were referred by clinicians because they had dilated ducts, but normal liver function tests. Only 7%, which actually is pretty similar to the rate we had before, had bile duct stones. In other words, the incidence is no higher than those patients with normal LFTs and non-dilated ducts. It's not that we missed any other pathology. We looked at and saw whether they came to any other operations or investigations afterwards. And actually, only 40% of them on an MRI scan were what they considered to be dilated. They were measured inaccurately. And of all the patients in this subgroup, who had had previous cholecystectomy, none of them had stones. So for this group, we can stop referring them for investigations. There's a huge resource implication saving there. But what about if they've got abnormal liver function tests, which are the two groups here? There's a difference between the dilated and the abnormal the dilated and the non-dilated duct group, as you'd expect in those referred for MRCP. But when you actually looked at the total group, i.e. not just the ones referred for the MRCP, the difference for those with non-dilated ducts is again not so dissimilar from the patients who didn't have abnormal liver function tests. So if you want to screen out, pick the ones with the dilated bile ducts and the abnormal liver function test. If you want to screen out even further, select the diameter of your duct. So if you've got the highest risk group of all are those with abnormal liver function tests and a duct greater than 10 millimetres, about 40% of those will have a stone. And if you're going to pick a group that you want to investigate preoperatively, then that's probably the ones that you would do your MRCPs on. And if you want to do ERCP, clear the duct, and then do your lap chole afterwards, that's the group. The group with non-dilated ducts and normal liver function tests, probably the easiest. Just do your lap chole, and depending on your bias, whether you believe everyone should have a cholangiogram for safety or not, do your cholangiogram. And the middle group, those with normal liver function tests but dilated ducts, as we've seen, very small incidence, but you may still want to pick up that small incidence, or those with abnormal liver function tests but non-dilated ducts, incidence of about 15% stones, just do a cholangiogram, so long as you have a plan for what you're going to do afterwards. And if you do find stones, so in the 85% that you find stones, are you going to do your bile duct exploration, lap or open? Probably depends on the size of the bile duct. If it's less than 8 millimetres, you probably wouldn't want that approach. Very, very few centres do an intraoperative ERCP. Not popular in the UK, but very popular in Australia. Put an antigrade stent through the cystic duct so that you know that you'll be able to do an ERCP afterwards. Or for what happens, I believe, in most centres in this little subgroup, is that you secure the cystic duct, and that really should be done with several clips, or preferably a locking clip or an endo loop, and then go on to have your post-op ERCP. So what's the worry about that approach? What are we scared of with it? Well, there are immediate features. Will they get a cystic duct leak if I've missed the stone? Will they get pancreatitis or obstructive jaundice if I've missed the stone? Remember, this is a subgroup that didn't have jaundice or significant cholangitis beforehand. Or will we be able to get that stone out if we do have a stone? So cystic duct stump leaks are actually, there's not any real evidence that CBD stones are higher in this group. So this study, with a large number of leaks reported from multi-centre things, actually found none, which is almost unbelievable, of those patients had CBD stones. But they did note that the leaks were twice as high in the acute cholecystectomy group, and that's, again, in the hot choles, we need to make sure those bile ducts are cystic ducts are secured. And this small study, again, found no higher incidence of bile duct stones. So cystic duct stump leaks are higher in emergency cases, and we should make sure that the stumps are secure. And it may be it's because the cystic duct gets necrosed, or perhaps the swelling dies down post-inflammatory when you remove the gallbladder, and that's why there's a higher leakage rate. There's actually some studies that show that there's a higher incidence after your cholangiogram. That's probably where the clip's taken off and there's a small tear, and the clip that you use to secure the duct is above it. But there doesn't seem to be much evidence that there's a higher incidence of CBD stones. What about pancreatitis? There are anecdotal stories of patients who've had their cholecystectomy and then had pancreatitis afterwards. But is this borne out in the literature? This is an American study, SAGES, looking at local centres, and only 2 of their 4,000 patients had pancreatitis after elective lap choles. And in this big Swiss national audit study, looking at 10,000 patients and looking at the codes for readmission with pancreatitis afterwards, there were 32, higher in the group of laparoscopic converted to open, but only 4 of those 32 patients, 4 of the 10,000 patients had pancreatitis associated with the CBD stone. So the incidence is tiny. But will we be able to get the stone out if they do have a stone? Well, there isn't really any study we can really relate to that, but other than to say that most ERCPs now would report 95 to 98% if you go from 1 or 2 ERCPs, clearance of simple stones from the bile duct. So that leaves us our algorithm. Just to recap very minimally, if you've got normal liver function tests, you've got a very small risk of bile duct stones, just do the chole. If you've got abnormal liver function tests and non-dilated ducts, or a normal liver function test and dilated ducts, there's a small risk of stones, less than 15% in this group, around less than 10% in this group, and it's the most cost-effective and time-effective management is probably to do an on-table cholangiogram. You could do the same for this group. You've got to know what you've got to do with your stones afterwards, or if you want to be more cautious, an MRCP and clear the ducts before. And that may relate on which hospital you're in and your local resources. So in summary, I do believe that a pathway for acute biliary disease could lead to a drive up of standards in management for gallstone disease. I'd just like to acknowledge Christian Mikutovic, who helped draft the paper originally, the SWORD database technicians Adam and Simon, and some of my registrars for collecting some of the data for me. Thank you.